Hi, everybody. Everyone seems to be here and quiet, so I'm just going to start with some housekeeping things. Thanks for coming to Symposium 27, Things We Don't Talk About. We're really excited to talk about extrapulmonary disease in CF and how it impacts your patients. A few things, there are two sections where you can put things in the app. If you can put your questions under the question section rather than the discussion section, and if it's possible to say who the question is for, what speaker it's for, that'll just help us keep track of things. And we'll go ahead and get started. So I'm Catherine Cutney. I'm a pediatric endocrinologist from Rainbow Babies and Children's Hospital in Cleveland. My co-moderator is Tony Fisher, a pediatric pulmonologist from Iowa. And we have no disclosures relevant to this presentation. And so I'm just going to introduce you to the topic and kind of how we conceive of the importance of talking about extrapulmonary disease and cystic fibrosis. So the decades-long story of cystic fibrosis is improved longevity. And through these decades, more and more has been learned about how cystic fibrosis affects areas outside of the lungs. And we've come to understand that CF is really a multi-system disease. Specifically, it impacts the GI tract, the exocrine pancreas with pancreatic exocrine insufficiency, liver disease, disease of the small intestine and colon. Of course, my bias is for the endocrine manifestations of cystic fibrosis, the impact on the endocrine pancreas, but also many other endocrine organs, such as the adrenal gland and the bones. CF has a big impact on male reproduction and female reproduction, as we're seeing with the baby boom among people living with cystic fibrosis, and can also have cardiac and many other extrapulmonary manifestations. And so the purpose of our symposium is to bring together basic and clinical researchers to generate ideas. What do we need to know about extrapulmonary disease and cystic fibrosis, and how do these organ systems interact with each other, and how can we work together to better solve these many, many remaining questions for our patients? So we're going to move our order around a little bit, but the talks that we will be presenting for you today, first we have Dr. Sylvia St. Petri presenting on the prevention and treatment of meconium ileus. Dr. Romina Fiorotto will be teaching us about the pathogenesis of CF liver disease and implications for treatments of our patients. Dr. Katie Larson-Odie will be presenting on pancreatic disease and CFTR modulators. And Dr. Raksha Jain will be helping us learn more about male infertility in the CFTR modulator era. And so as I said, we're going to move our order around a little bit. So first I'm going to welcome Dr. Katie Larson-Odie. So Dr. Larson-Odie is a pediatric endocrinologist and a clinical professor of pediatrics at the University of Iowa. She's also one of the Envision mentors for the Envision 2 program, and so I've had the pleasure of working with her and learning from her a lot. Welcome, Dr. Larson-Odie.
All right. Thank you guys all for coming to the session. Thank you guys for inviting me to speak. I get to talk about something that I really like. So I do have a relevant disclosure. I have received an honorarium for Vertex, and I will be talking about their medications during this presentation. So that is a relevant disclosure. So I'm going to talk to you about my favorite organ, which is the pancreas. And this is a normal pancreas, and it has both parts of the pancreas. And I think we spend a lot of time separating the two parts of the pancreas. The outside part that is pink and purple and so pretty, that's your exocrine pancreas. And the inside part is your endocrine pancreas, or the islet, which of course I'm an endocrinologist, that's my favorite part, but actually it's all important. And this is, I like to put this up because this is the pathology slide from Dorothy Anderson's original paper when she first described cystic fibrosis. And I like to put it up there because this was a pancreas disease before it was an anything else disease. And before we had enzymes, everybody died from failure to thrive from their pancreatic disease. So because I am a pancreas person, I like to just point that out, how important the pancreas is, because sometimes we don't think about it. So I'm going to flip back and forth between endocrine and exocrine pancreas in the context of this trial. So exocrine pancreatic disease in people with classic CF begins in utero. And even in our pancreatic sufficient patients, there can be evidence of this. And 85% of our people with CF are fully pancreatic insufficient from childhood. There was new data that I saw earlier. This earlier this meeting, so I updated this slightly. So it turns out the most recent data is most people are pancreatic insufficient by 8 years of age, and exocrine loss is essentially complete by 10 years of age. And this persists. And from the PROMISE data, it does not resolve. So the natural history of the endocrine pancreatic disease in people with CF is they have progressive insulin deficiency. And the insulin deficiency is present very, very young. And the thing about people with CF is people with CF who have classic CF essentially don't ever have normal insulin secretion as best we can tell. Every time we look at it really in-depthly, we don't find that it's ever normal. And the most common thing they have is lack of early insulin secretion, even if they always maintain normal glucose tolerance throughout their whole life. And I just said that. And actually, the exocrine disease is a really, really good predictor. So exocrine disease and age are our best predictors of diabetes in people with CF. But if you look really hard on our people that are pancreatic sufficient, they can still have abnormal glucose tolerance. And so it's really kind of an essential part of CF to not have normal endocrine function. And exocrine and endocrine disease are very tightly interwoven. The worse your exocrine disease is, the more likely you are to have endocrine disease, and the sooner it's going to show up. And another thing that we forget about in the age of correctors is that glucose tolerance in people with CF, at least historically, waxes and wanes. So people do progress over time. The second biggest risk factor after exocrine problems is age. So this gets worse with age. Very much. That's the strongest predictor other than exocrine disease. And people have a gradual progression, typically, of their glucose tolerance abnormalities. Importantly, in CF, and different from other kinds of diabetes, fasting hyperglycemia is a really late finding, which is why we have such a hard time with all of our screening tests. And the other thing that's important to remember historically is that even if your OGTT, which is our routine screening that we use in CF because of the issues with fasting hyperglycemia, even if you get better, your worst OGTT that you ever had historically predicts long-term clinical outcomes for our patients, which historically was decline in lung function and problems with weight maintenance. So our best animal model for endocrine pancreas disease in CF, in my very biased opinion, but I think I'm right, is the CF ferret. And so this is a picture of what happens to the CF ferret's pancreas very early in life. And so they are born with a much better looking pancreas than what you see in a person with CF. There is just a little bit of ductal dilatation, but otherwise it looks pretty good. And then they have rapid progression of pancreatic fibrosis and pancreas destruction, and then they have very rapid inflammation of the pancreas. And the cool thing about that is that's actually very predictive of what happens to their glucose. So this is a picture of some of the data from the CF ferrets. And this blue ferret is a SIB without CF, and then this red is the SIB with, and the two dots are before and after they eat. So, and what you can see is these very little ferrets have a phase where they're like kind of okay right after birth, and then they get really markedly abnormal blood sugars that then subsequently improve and then slowly worsen with age. And that actually is a very good recapitulation of what we have from people with CF. And so I did some testing a long time back showing that kids 3 months to 6 years of age can have abnormal glucose tolerance. And then there was some data presented at this meeting showing abnormal CGMs in very, very little kids with CF. But because of the waxing and waning, it's not a steady, you get this kind of gets bad and then it gets better and then it gets bad and then it gets better. And so that's what we kind of know. So what everybody cares about and what I get questions about the most is what do correctors do for the endocrine pancreas? And so there's a lot of different options, actually. So I used to be really hopped up that there was going to be CFTR in the beta cell and that we were going to start correctors and everybody's diabetes was going to get better instantaneously because there was CFTR in the beta cell and we were going to fix it, right? So that would be cool. And then, of course, if it's not in the beta cell, maybe it's in one of the other islet cells, which would make a difference. And then, interestingly, something that I didn't think about as an endocrinologist, because we used to really separate it, is maybe there's something in the exocrine pancreas that's essential for the function of the endocrine pancreas. I might be leading you. Okay. And then, of course, inflammation is this really, really, really important to CF, and inflammation occurs everywhere in CF, not just in the lungs. And so potentially we could resolve inflammation, and that could be a big part of the story. And then, of course, one of the scenarios is that islets could be dependent on a normal structure of the exocrine pancreas to function properly, and we may not be able to fix things unless we can start correctors before the exocrine pancreas destroys itself. So those are kind of our options in my brain of ways that correctors could help endocrine function in people with CF. So I kind of led you into this one, but the big question for a long time was, is there CFTR in the beta cell? And this actually was very tantalizing because CFTR is actually ontologically related to really important ion channels in the beta cells and the alpha cells. So the sulfonylurea receptor is an extremely important channel that actually controls insulin release. And CFTR is very closely related to it. Beta cells are very dependent on their ion flux across the membranes in order to function. So it's actually really super tantalizing. And people found it. It was so exciting. But then it was unable to be replicated. And it turns out, and especially anybody who's ever taken care of somebody who has CFRD who got put on a modulator, like the diabetes doesn't go away. So this isn't there probably isn't substantial amounts of CFTR in substantial amount of islet cells. There might be a little bit of CFTR in a few of the islet cells, but it's not the problem. It's not the primary problem, and it doesn't just get fixed, which is very sad. And that's pretty much true for all of the islet cells. We went through each of them, like maybe it's in this one, maybe it's in this. No, sorry. So that's not the problem. But we know CFTR is outside the islet. The exocrine pancreas is incredibly CFTR dependent. And the cool thing that I sort of telegraphed earlier is that it turns out the exocrine pancreas absolutely helps the endocrine pancreas to function. So this is some really pretty data from some of my immediate colleagues, Dr. Norris and Dr. Engelhardt. And what we forget in endocrine is that when you isolate an islet so you can experiment on it, we think we really have an isolated islet. Turns out you always have ducts. You can't get an islet without ducts attached to it. So so this is a very elegant experiment that I just love. So they just took isolated islets from both ferrets, not with CF, normal ferrets, normal people. And they did shRNA knockdown of CFTR in both human and ferret islets. And the blue bar is a scrambled shRNA, so it doesn't do anything. That's the control. And the red bar is the functional shRNA, so it knocks down the CFTR. And the first thing is low glucose. If you're looking from left to right, it's low glucose and then high glucose, and the bars are measuring insulin secretion. You shouldn't be making insulin when you have low glucose, and when you have high glucose, you should make lots of insulin. And it's pretty straightforward when you look at these bars that if you knock down the CFTR in the duct cells in an isolated islet, so there aren't very many duct cells in that sample, you are getting a lot less insulin secretion from those islets. And both in the human islets and in the ferret islets. So there is something that the duct cells are doing that's helping the islets do their job. Dr. Engelhardt is trying to figure out, his team is working on this more. But I just like to throw that out there because this was actually kind of mind-blowing to me because this was not what I learned about how islets works when I was learning about islets. So to pivot a little bit to inflammation, it turns out islet inflammation is happening in CF. You can find pretty important cytokines, typically IL-1 beta, and within the beta cells, which are the important cells that make the insulin, you find T cells in the CF islet, including the kind of T cells you see in people with type 1. And then in our CF pig model, we see elevated reactive oxygen species that are affecting insulin secretion. And so far, we haven't found anything that fixes that. And then I'm currently in love with macrophages. So, I'd probably be wrong about this like I was about the CFTR in the islet, but hey, I get excited about stuff. So macrophages are really important to islets. And the thing about macrophages is every tissue macrophage is unique and has its own special role. And it turns out that you need, not in CF, but in other models we've seen, especially pancreatitis, you need islet-resident macrophages to have regrowth of your islets after inflammation and destruction. And in the dysglycemia and the CF ferrets, when they have that big loss of function and then they get better, they are essentially regrowing a lot of their islet tissue. And islet regeneration is really important to that process. And so, and when people who have looked at adult pancreata from people with CF looking for islet macrophages have been unable to find them. But we do know that people with CF have macrophage dysfunction, and it really looks like CFTR modulators can restore this. So it's possible that our modulators will, and this would be a longer process, right, than if CFTR is in the beta cell. This is going to take more time if we're kind of having the immune system improve and become less inflamed. So this would be an option for our patients to improve slowly over time if this is what's going on. And so what data do we have on whether correctors improve or treat diabetes or exocrine dysfunction? And so this is really rapidly moving. Like, I first made these slides like in the spring, and then I keep having to update them. So, and a lot of this was reviewed really well in the Pancreas on the Pedestal session. So for people who went to that one, you're not gonna see anything super crazy new here. Also, I stole some data from them to add to my slides. So, we've had ivacaftor a lot longer, and the ivacaftor data was not convincing, but it was very hopeful. So all the studies are really small. These are the ones that I think are the highest quality studies because that to go through. And so the first one was by Dr. Bellin, and they just had 5 patients. They were just on ivacaftor for 4 weeks, but they showed a pretty substantial improvement in insulin response, except in one patient who had really long-standing diabetes, which we're presuming their beta cells were all just dead. And then Andy Kelly did a really elegantly done study with really high quality assessments done, and it's like 20 patients. I can't quite remember should have put the N on here. And what they found is they didn't find any improvement in the glucose values with ivacaftor, but they did see improvement in acute C-peptide, which is related to insulin response. And then the registry data is pretty awesome because what they showed was that there was a lowering in the new incidence of diabetes in 5 years post the initiation of Trikafta, which is we're all hoping that these things will at least keep people from developing diabetes, right? And so it seemed to be the case with ivacaftor alone. So of course we're all interested in ETI. There isn't a ton of data yet, but there's a lot more all the time. And so this is a nicely published study. And what they found here is there's a couple of important things in this slide. So they found that the A1C decreased very significantly in their population. And then the other thing that we all know, which we just had a bunch of great sessions on yesterday, is that the patients shifted their weight category. So they had a lot less underweight patients, they had a lot more overweight and obese, and they had less normal weight patients. And we have all, if we do clinical care, experienced this. But this does have implications for the type of what's going on. And there's a wonderful session right now talking about insulin resistance and kind of type 2 phenotypes in people with CF, because we may see more of this. So, and then here's another study where they looked at CGM markers of glycemia in people on ETI. And they didn't see any difference with people with CFRD and people who didn't have CFRD. So like all the CF patients improved, and it wasn't different whether or not they actually had a diagnosis of diabetes. But basically their average glucose improved and their time high improved, which is really great. So how about the exocrine pancreas? And this is mostly ivacaftor data. So there's just this really fantastic review if you want to know about what we know about what highly effective modulators do to the exocrine pancreas. This is a great study. One of the people who was on this study spoke at the Pancreas on a Pedestal talk, and this is a really, really good study. So if you really want to know, I would recommend that you read this. They did a very good in-depth dive. But to summarize it, a decent number of people who are pancreatic insufficient become pancreatic sufficient, but it's younger people. And so, it matches very closely that data on when you become exocrine sufficient. So the people who got better were people that were under 10. And in the studies they found where they actually measured exocrine, as opposed to just whether or not the person was classified one way or the other, they found that decent chunk of the people that were looked at actually had improvements in their fecal elastase, but all the people who got better had detectable fecal elastase. So if you have no exocrine tissue, you're not going to recover. But if there's some exocrine tissue there, it turns out, well, not shockingly, highly effective correctors are great for your exocrine pancreas. And this picture from the review just shows the absolute change in the fecal elastase that was seen in the studies, which is pretty awesome. So, of course, our ferrets are a great model. And so this is some of, I think, this is really interesting data. I think this is also ivacaftor data. So Dr. Engelhardt and team have G551D ferrets. And this is just a study where they compared homozygous G551D ferrets to heterozygous, and the other one's knockout, so that's a zero function mutation, right? And they put them on ivacaftor in utero. And so, and then they actually tested the CFTR function, so that you saw how much improvement in CFTR function you actually got. And so the homozygous ferrets on ivacaftor from utero did not have exocrine or endocrine disease. In the heterozygous ferrets, some of them did, and some of them didn't. And it does really show that you have to correct to a certain threshold to fix the exocrine pancreas. But more disturbingly, when you stop it, it's a problem. So when you stop highly effective corrector therapy on somebody who's been on it when they still had exocrine function, they rapidly develop pancreatitis. And some of those patients will then also ferrets, but probably also will rapidly develop glycemic instability as well. And this has been a big concern in which will be relevant to future talks, in our pregnant patients who are on ivacaftor. If they have a baby who has CF, they're going to be treated in utero, and this has happened. So we have babies that are inadvertently treated in utero, and there's a couple things that happens with that. One of them is that our newborn screen is dependent on evidence of in utero pancreatitis. So if you don't have an in utero pancreatitis, you will pass the newborn screen because it picks up trypsinogen first, and the reflexes to the gene testing in pretty much every state, as far as I know. So that's one part of it, and then the other one is, of course, if the mom can't breastfeed, the baby will withdraw from the treatment. And then we worry about this. So there are other people who, I haven't taken care of any cases of this personally, so I don't have, but I know there are people at this meeting who have gone through this process with human babies. And so new things that happened since I got here at NACFC, there was a really nice paper with a really nice poster with a lot of subjects from Europe, and they found they had a significant decrease in A1C in all of their groups. They nicely broke it out to people who had CFRD, people who had normal glucose tolerance, people who had impaired glucose tolerance, and they also broke out by whether they'd been on a different corrector before they started ETI. And all those groups had reduced A1C. And then I talked about that pace. So turns out, a couple more cool things. It turns out that CFTR, not CF-causing mutations, but other mutations in CFTR that don't cause CF, are a really strong modifier gene for type 1 diabetes, and are probably a trigger of islet inflammation for people with type 1. And also other things that I have learned is that people with type 1 often have smaller exocrine pancreases than normal. A lot of them do. Ooh, so cool. Okay, and then there's abnormal fibroblasts in the exocrine pancreas can secrete mediators that affect glucose-stimulated insulin secretion. So not just the duct cells, but also the fibroblasts can be messing with the endocrine pancreas. And then from the PROMISE data, which is what we all wanted, what they noticed were there are no changes in measures of glucose excursion. They did find a decrease in A1C, just like that poster 006. And they found, just like all the other smaller studies, small increases in early insulin and early C-peptide release. And they didn't find any improvement at all in exocrine function, but that data is 12 years and older. So to sum up, all the things I just said, corrector therapy does positively impact both the endocrine and the exocrine pancreas, and especially the exocrine pancreas. It isn't, in my opinion, as a CF endocrinologist, we're not going to cure people with established CFRD. I just have enough clinical experience to know, like, my people who are on insulin Maybe they need a little less insulin. Some of them might not need insulin, but most people still need insulin. And I do know that like in the first couple years after we got ETI, I didn't have any new insulin starts, except people who weren't eligible. But I've started having new insulin starts again now. So corrector therapy does not get rid of established damage to the pancreas that causes endocrine disease. But it probably will prevent it and potentially prevent progression. And I do think if we can start it young enough to rescue the exocrine pancreas, then we may, I might probably have this on here. Whoops, what did I do? I did something funny. Okay, all right. So, and then we also know that this isn't gonna cure the exocrine pancreas if people are too old and have taken too much damage. And so to really prevent exocrine and endocrine disease, we're gonna need to start it early. We're about to do this. So this is happening in real time and we're gonna see it. And I think, right now, the age at which we have to do it, I don't think we totally know. Less than 2 years in utero, is it okay if they start less than 10? Is it gonna help? And then the other thing I think that we don't talk enough about is whether people are gonna take their meds. And as a pediatric endocrinologist, it is really hard to get young people to take a med when they feel great. So, and these meds have to be timed properly. They have to be taken with food. I'm already having to talk to my patients all the time about whether they're actually taking both doses of their Trikafta. And so the problem is if we have people who, decide they aren't gonna do any of their cares for a week, they're gonna have, it's gonna damage the exocrine pancreas. And then somebody with an intact pancreas, and there is data already to show that, you do see more pancreatitis. So this is gonna be a new thing. And the thing about our patients is historically they've been really sick, so they're really motivated to take care of themselves. But when we start people at 2, they're gonna be completely healthy, right? They're not gonna know what it's like to feel bad from CF. They're gonna be like, I take this annoying medication and I'm fine. So I think this is gonna be a thing we're really gonna have to pay attention to long-term because I do think this is gonna work and these things are gonna be better. But we're gonna be in trouble if people aren't taking their medicine the way they need to. And that's my presentation. Thank you guys for listening. Do I run away now? What do I do?
Stay here for,
Okay,
so
stay
we'll
here for
have
questions.
a couple minutes for questions for Dr. Larsenodi. Thank you for an awesome talk. That was fabulous.
I
overview.
care about this topic very
Yes,
much. Can
I
you
can tell it comes through. So put your questions under the question section in the chat and put the speaker's name first if you have any.
Yeah, that was a fascinating talk, Katie. One of the themes that you're bringing up here is, are there developmental windows in which we have the opportunity for harm and opportunity for gain? For instance, what's the window of opportunity for islet cell regeneration in these patients? By, maybe you're showing that by the time they reach adolescence, it may be too late, but what's the window of potential for harm from modulator withdrawal?
That's a good question. So, what a good question. So what we know, I think and I'm not an expert in type 1, unlike some other people who might be in the room, but I think what we know from the type 1 data is that you can regenerate endocrine cells until I think your early 20s, I think is what it is. I would say in the CF patients, based on the data we have, I think the problem is that you need a functional exocrine pancreas to regenerate your endocrine pancreas. And so I think the window for CF is going to be a little bit different than other types of diabetes because we're working with a very broken exocrine pancreas. And it's, from what I understand, it's pretty essential to have an exocrine pancreas to regenerate the islet. So I think our critical window will be when we have enough exocrine pancreatic tissue left that we can support it to regenerate. I think and I think when you look at the ferret model and the little bit of people data, there is some regeneration happening probably in early childhood that then you're kind of losing ground again. And so I think there's probably definitely in very little kids in early childhood, there's probably going to be a chance for regeneration. I think once you get older teens, just like you said, or definitely into adults, I don't think we're going to get much. I think in adults, it's mostly reduction of inflammation, reduction of just active illness, and insulin, and things like that. I think is probably more what's going on in adults rather than any kind of regeneration.
Are there other therapeutic targets that we should be aiming at aside from CFTR? You alluded to inflammation. You alluded to these other cells that might be there in this milieu, such as lymphocytes and macrophages.
I don't know, but what a great question. I'm pretty sure that a lot of the things that we're doing that are going to help other things in CF will also help the pancreas. I do think that, addressing the inflammation stuff, inflammation is really bad for, beta cells are wimpy. Islet cells are really wimpy. They're easy, they die easily. So anything that makes the milieu healthier is going to help retain the function there. So I do think that that's going to be really important, but I don't actually know anything about that particular area.
All right, I have one question from the audience. Can you clarify if the babies who received modulators in utero and then had pancreatitis had CF or were normal babies?
Oh, it's people with CF. So they're going to be, so the babies that we worry about are the babies that are homozygous for CF mutations. And so as far as I know, a lot of them were unintentional pregnancies and they were unaware that the father was the CF carrier. But I am not directly involved in any of these cases, so so don't pin me to the wall on that. But yeah, it's only going to happen in people who have classic CF, because people who have CFTR associated syndrome or are heterozygous, they do not get pancreatitis in utero. You have to have classic CF to get pancreatitis in utero. So,
all right,
that's a great question. I should have clarified that a little bit better.
We're seeing some questions coming in from the audience. So one of these, could it be the PROMISE data that shows no recovery of exocrine function is just too soon to show improvement? And will it occur over a longer time period? So with longer follow-up, are we going to see it?
So that's a great question, and I know they're following it, and the CF Foundation has funded PROMISE out to 52 months to see if there will be continued improvements over time that we're missing. If you want my personal opinion, which you have to remember, I'm often frequently wrong, I don't think we'll see anything from the exocrine pancreas in people that are older, because I really do think it's dead. But I would love to be proven wrong, and hopefully I will. And the CF Foundation is smart enough to know that we need to actually look at that and not just assume things. So the PROMISE is getting extended out to 52 months is my understanding. So that will help that question. That's pretty long follow-up, so we should be able to see something by then.
We have a question here that may also be very good for a future talk. Can you clarify if babies who received modulators in utero and then had pancreatitis had CF or were normal babies?
I think that's the question I just got asked.
Okay.
Yeah, sorry. The app is not very nice to them. I'm so glad I'm not moderating anything.
And then, I apologize. And then this is a very provocative question.
Okay.
Here, just for the sake of talking, what if ETI was administered as an implant, like a contraception device? Could this resolve adherence issues?
Oh, absolutely. Yeah, that's a great idea. Whoever thought of that, go talk to Vertex, man. That's fantastic. Yeah, so it's interesting. The question of implants, that's a great question, because we actually, in endocrinology, we have continuous glucose monitors, and some of those are implanted, right? And so it kind of depends on the nature of the implant, but they are really nice for teenagers who are not motivated, right? I like to, when I'm doing birth control in my CF teenage girls, I really like it if they're on long-acting reversible contraception, so that I know that they don't get accidentally pregnant, because I hate accidental pregnancy in people with chronic illness. So I think that is a great, I don't know if it's amenable to that. The nature of the medication makes me think that would be pretty challenging, but if it could be done, it would absolutely solve a lot of problems. Absolutely. It's a great idea.
Let's see, and one last question here. Do you recommend or perform oral glucose tolerance tests in pancreatic sufficient patients? At what age and how frequently?
We don't know. I have pancreatic sufficient patients who have CFRD. I even have people who have CFTR associated syndrome who have, for all intents and purposes, CFRD, even though I feel like I can't call it that. So it's tough. The cool thing about people with less severe CF is it's probably less of a problem if the diagnosis is delayed. So In classic CF, we really need to get people before they're as diabetic as what we would treat in any other discrete population, because they get historically lung function decline and BMI decline before they really have what we would think of as diabetes. And I think and this may be true in post-ETI, we may not get in trouble with these very mild glucose excursions. They may not be clinically important. We don't know. But then the one good thing about our pancreatic sufficient patients is their diabetes is very rare in that population. And I do think the healthier patients, you have less of a problem if it takes you a little time more longer to pick it up. We wrote something in the guidelines. I don't remember what we wrote in the guidelines. We don't have enough data.
Okay.
Very good.
Thank
Thank you so much, Katie.
Yeah, thanks.
All right, I have the pleasure of welcoming our next speaker, Dr. Sylvia St. Petri. Sylvia is an assistant professor of pediatrics and a pediatric pulmonologist at the Medical University of South Carolina, as well as the center director, and she will be talking to us about the prevention and treatment of meconium ileus. Welcome, Sylvia.
Thank you so much for that kind introduction, and thank you, Dr. Odie. I don't know that I could have asked for a better precursor talk to lead into discussing meconium ileus. So I have no relevant disclosures for this discussion. And our objectives for today are to walk through sort of the current landscape as it stands with meconium ileus. We'll walk through definition, we'll walk through the patients that undergo diagnosis of meconium ileus, why it occurs in those populations, the current standards of care for treatment, what happens to those patients long-term, and then more of an in-depth discussion on how it might be prevented, which we've already touched on a bit. So, as many of us know in the clinical world, meconium ileus is one of the first manifestations that we may find of cystic fibrosis. Because of the thick, sticky meconium stools that are in utero, obstructions can occur in the small bowel, typically in the terminal or final portion of the ileum. They can be diagnosed prenatally and either may be identified as hyperechoic bowel, as seen in the image on the right, or dilated bowel, which is shown in the image on the left. And it occurs roughly in 1 in 5 of all infants born with CF. So meconium ileus may show up in two sort of disparate forms: simple as an obstruction, as we discussed, or there may be complications associated. So you may see not just a bowel obstruction, but also ischemia of the bowel, turning of the bowel on itself, or volvulus, intestinal atresia, where downstream damage occurs to the bowel based on those issues, or pseudocyst formation, where the bowel becomes very largely distended with mucus and other fluid, or even peritonitis or perforation, where there's leakage of bowel contents into the abdominal cavity. Clinical presentation, depending on whether meconium ileus is simple or complex, could be simply bilious emesis, or you could have an infant that presents with shock and sepsis. Typical diagnostic steps in the neonatal ICU would include abdominal imaging, films, or MRI. And then if contrast enema is possible in a stable infant, the potential to reduce the meconium ileus is typically attempted. And then again, based on the clinical picture of the infant, whether they are acutely ill or stable, you would pursue either medical or surgical treatment. So again, roughly 1 in 5 or 20% of CF infants will present with meconium ileus. It tends to be more commonly seen with certain mutations, class 1 through 3 FTR, CFTR mutations, so commonly F508del, G551D, and others. If you're a delta F508 homozygote, you have almost a 25% chance of presenting with MI, as opposed to a heterozygote, roughly 17% chance, and for those with no copies of delta F508, it's closer to a 13% chance. Treatment, as I mentioned, can be either medical or surgical, so either a hyperosmolar fluid attempting to normalize the lumen of the bowel under fluoroscopy. That's been going on since roughly 1970. Or in infants with a more severe clinical picture, we see surgical interventions with irrigation of the bowel with saline or other substances, enterostomy to open the bowel and allow for a more direct irrigation. And then in cases where damage has occurred, we resect the bowel and either immediately or in a delayed fashion reconnect the portions of the healthy bowel that remains. In the majority of these patients, they do require significant nutritional support. And so since they're not able to eat by mouth, we use TPN or parenteral nutrition, which comes with its own risks and benefits. Long-term, what do we know about these infants? So we have sort of two eras of meconium ileus infants to review. One is that in the pre-newborn screen era, in infants who are being diagnosed based on clinical symptoms rather than being identified through our state newborn screen processes. The first study I'll touch on was from 2006 and was a case cohort study with 52 patients followed from age diagnosis until 15. They showed similar growth trends, both in height and weight Z-score, and their lung function was overall without a significant difference, both early in age, at age 6, again repeating testing at age 10, and also again at age 15. The mean diagnosis, I would point out, for those with meconium ileus was quite a bit earlier, so 1 month of age on average, compared to 3.5 months in those without meconium ileus, which I know many of us would agree is pretty unacceptable in the newborn screen era. Then in 2010, there was a single center study looking at 38 patients with MI and 76 without. They again showed no significant difference in lung function or growth parameters, no significant difference between groups as far as genotype, sex, Pseudomonas infection, or need for pancreatic enzyme replacement therapy. But the median age of diagnosis in the meconium ileus group was just 1 day. Compared to those without meconium ileus, it was 7 months, which is quite a startling difference in the two groups. What do we know about these infants long term? So one study looked at 162 pancreatic insufficient matched pairs. Meconium ileus patients between ages 5 to 23 years had FEV1 that was 7% lower compared to non-meconium ileus patients. And that's demonstrated in the graph at the top. And the meconium ileus patients between ages 2 and 20 had a significantly lower BMI Z-score over time, demonstrated in the graph below. And overall, meconium ileus patients were more likely to receive nutritional supplements and gastrostomy feedings. What do we know more in the short term in more recent years? So there was one infancy-focused multi-center study which identified 85 patients with meconium ileus, and they showed a very high rate of surgical intervention required. So 83% of the patients that they identified required some surgery, and 26%, in spite of that, had growth failure with either weight or length below the 3rd percentile at 1 year of age. 11% had chronic Pseudomonas infection at 1 year of age, and 70% had some intermittent Pseudomonas positive respiratory samples within that first year of life. So this brings us to a bigger question. With the data that we have, with the studies that have been completed, and with the modeling that we have, could prevention be something that's within our grasp? So animal modeling first began in the 90s with mouse models, and mouse models were initially demonstrated with severe intestinal obstruction, but without pancreas or lung involvement. There have been subsequently multiple mouse models developed, and we have a G551D model as well as a F508del model. And then more recently, as we've already touched on, pig and ferret models of CF that in the pig setting have 100% penetrance of meconium ileus, and in the ferret model demonstrate intestinal perforation in impacted kits. In the pig model in particular, there has been some positive outcomes with transgenic expression of porcine CFTR cDNA. So in 3 of the 5 lines that were followed in one investigation, there was at least partial restoration of CFTR function and anion transport with an improved intestinal phenotype. So some hope that meconium ileus could be rescued. And then again, more recently in the ferret model, we have meconium ileus rescue specifically with VX770. So in those ivacaftor responsive or VX770 G551D ferrets, the drug was administered and showed partial protection from development of abnormalities in the pancreas, the intestine, and the male reproductive tract. There was improvement in neonatal mortality outcomes, specifically related to meconium ileus, and postnatal VX770 administration led to improved pancreas exocrine function, growth, survival, and improved lung pathology. However, it is again worth noting that when there was drug withdrawal, pancreatic insufficiency, lung disease, and clinical decline occurred quite rapidly. So again, this brings us to the question of, with our knowledge, with our data, with our modeling, how might meconium ileus be prevented? We had a clue of this with last year's identification of a missed infant by newborn screening. So this was an F508del homozygous infant delivered to a CF-affected delta F508 homozygous mother on ETI in pregnancy. The infant's newborn screen was normal, so the findings from the pancreas were not identified. And sweat chloride values were also lower than expected at 60 and 67 millimoles per liter. Pancreatic sufficient status was identified, and growth remained really in robust range throughout the infant's first year of life. So this brings the question of, what do we do with modulators in pregnancy? We also know there's been increasing fertility, increasing numbers of pregnancies in women with CF, and that highly effective modulator therapy is improving overall health in those with CF, and we suspect increasing fertility. Animal models of CFTR modulators have not demonstrated fetal harm, and overall case reports thus far have been reassuring. And we have long-term data that's being collected with the Mayflower study, which will hopefully shed significant light on these questions. Maternal fetal outcomes are quite sparse today, but we do know that there have been a few complications reported, specifically with ETI. One case of cholecystitis, one case of cholestasis that could not definitively be attributed to ETI, and a pulmonary exacerbation in a similar setting. Postpartum complications have not been reported, and infant outcomes have been reported, including preterm birth, which were deemed unrelated to ETI exposure, but congenital anomalies have also been identified and are worth noting. Aortic coarctation, choroid plexus cysts, a ureterocele, and low-set ears, as well as a transient transaminitis. And most recently, just in the past few weeks, 3 cases of congenital cataracts were identified in infants exposed to ETI, either in utero or via breast milk. Pregnancy and lactation data is also quite limited. There was a 3-mother and infant pair study that were followed both during pregnancy and on ETI after birth, and it showed overall relatively high ETI levels in cord blood compared to those in breast milk and infant blood. There is suggestion of placental transfer, and I think in the case that we'll be reviewing moving forward, this supports this. So then we move to our case. I know many of you have probably heard this before, so I'll try to move through it relatively quickly, but I think it's a helpful example in where our landscape stands today. So our case is a carrier mother with 1 copy of delta F508 and an affected infant identified by amniocentesis homozygous for delta F508. Initial anatomic survey was normal, but 23-week ultrasound demonstrated a single dilated bowel loop, and the 28-week ultrasound showed persistence of bowel dilation with echogenicity overall consistent with meconium ileus. This is an image of that bowel dilation at 28 weeks and 6 days. And based on these findings, we were approached by the infant's mother. She was 34 years old at the time of pregnancy, again, a carrier with 1 copy of delta F508, with history of migraine, asthma, liver hemangioma, and gestational hypertension. There was a multidisciplinary discussion between the care team, the family, our neonatology group, and our obstetric group that looked at potential maternal and fetal risks, benefits, and unknowns, which were many. And through a shared decision-making process, the mother was initiated on standard adult dosing of ETI at age 32 weeks after normal baseline liver function testing. 13 days after starting ETI, a follow-up ultrasound showed no improvement in the echogenic and dilated bowel. However, by 27 days of ETI therapy, those findings had completely resolved. This is an image at 35 weeks, 5 days, demonstrating that resolution. And the infant was planned to be delivered by cesarean section at 37 weeks. However, she had other ideas. She came at 36 weeks and 1 day. And she was robust and healthy with no concerns in the newborn period other than the note of meconium-stained amniotic fluid. She was admitted to our neonatal ICU for observation and had a non-obstructed bowel film, was allowed to eat, began breastfeeding, and was initiated on pancreatic enzyme replacement therapy in light of her genotype. She passed multiple stools over the first day of life, had a normal bilirubin, and was discharged home on day of life 2. Mother continued ETI while she was breastfeeding, and we followed the infant closely after discharge home. Her state newborn screen was positive, so her immunoreactive trypsinogen was over 100, which was within our top 4 percentile of results in the day, which is our South Carolina state newborn screen algorithm. Her sweat test was lower than expected, so 64, 62 millimoles per liter within the first 4 weeks of life. And she had lab results that were also reassuring with transaminases, bilirubin, and then an eye exam, which were also within normal limits. Mother breastfed or provided express breast milk through roughly age 4 to 5 months, and we monitored her fecal elastase closely. Overall, her results remained in the normal range for our lab, above 200 micrograms per gram, except for one single stool sample that was more loose. In hindsight, it does raise the question of whether in that sort of rocky transition period, could she have been experiencing withdrawal symptoms? And I think this is an important question to consider. Her weight improved dramatically over the first few weeks of life. So she went from the first percentile of weight corrected for gestational age to the 30th by age 5 months. Her length, which we follow very closely in CF, also followed suit. And her weight for length had even more robust improvement. So in summary, we have an infant who received ETI exposure in utero and post-delivery through breast milk with multiple areas of perceived benefit. Her meconium ileus resolved. She avoided many of the sequelae related to meconium ileus with prolonged hospital stay, multiple surgeries, stress, parenteral nutrition, stress on the family and caregivers. She retained pancreatic sufficient status, which I think is remarkable for an infant with her genotype. And her growth trajectory has continued to improve, both during ETI exposure and since transition from breastfeeding, now on early access or CAMBI. So overall, we concluded that there was quite a significant amount of potential benefit in this case from prevention of both pancreatic and other organ damage, and that this would be helpful to consider in other cases moving forward. So again, how might we prevent meconium ileus? We present just a single case. However, this is in tandem with a number of other infants who've been identified over the past few months with similar clinical scenarios, whether meconium ileus or other health effects are noted. We need to think about the timing of our intervention. How could this be applied to others in the future? What's the duration of treatment that might be needed? In our case, it was only 4 weeks when the area of concern resolved. What might be optimal dosing? And when might we consider rather treatment with ETI in an infant rather than with Orkambi, which is closer to our FDA approval for her age range? And then thinking about post-delivery, not every baby has the opportunity to breastfeed. What should we do in regards to health and safety outcomes for both infant and mother? What should we think of in regards to early access? And again, the consideration of medication withdrawal, I think is an important question to consider as well. So overall, I think the big takeaway is that additional data is critically needed to help explore these questions. And I'm hopeful that we'll be able to get these answers in clear form over the next few weeks to months. I want to acknowledge our patient, their dedicated family, our care team, and the CF community for all their support. And I'd be happy to take any questions.
That was a fascinating talk. Thank you very much. One thing that strikes me is that many of the CFTR alleles that are associated with meconium ileus are stop codon alleles, such as G542X. And yet, the appearance of meconium ileus in humans is 20%, suggesting that there are factors outside of CFTR that might control the risk for developing meconium ileus, and some others in the audience have done GWAS studies or mouse model studies looking at some of those second sites. What are we going to do in the future for babies who may be ineligible for CFTR modulators? Are there other options for treating them in the future?
That's an excellent question. I believe I heard you mention some use of pancreatic enzyme replacement therapy as one potential sort of physical tool to be used in the setting of identified meconium ileus, I presume post-delivery. I think it's...
Are there alternative chloride channels or other things, maybe that could be targeted as well?
Certainly, I think additional investigation absolutely would be of benefit, in particular for those patients who are most vulnerable, who wouldn't have access to a modulator, especially after delivery. I think helpful to consider those patients as well in the greater landscape. But I think the pathogenesis of meconium ileus is complex and I agree needs further study.
We have a number of upvotes for this question, so I'm going to pose it to you. And now, until ETI will be permitted for this baby, what would you suggest to do? Now, I think what they're kind of getting at is you were able to put this patient on Orkambi,
Correct.
transitioning after the breastfeeding stop. But
Correct.
Could you talk a little bit more about the time course of that, and was it any hoops you had to go through to get the Orkambi? And I think also, what would you recommend if somebody was thinking about doing this in another patient, pregnant patient with a baby who may have CF? Do you need to ensure ahead of time that you have access to a modulator for those patients?
It's a great question. I think the challenge with meconium ileus identification and treatment is that often it's not found until probably at the earliest halfway through the pregnancy. And so that leaves a very limited opportunity of time to intervene. We were delighted to see that in our patient that there was a response within 4 weeks of treatment. And so I would be hopeful that moving forward in other cases that there would be a window of opportunity within that 4 or maybe even we might find 3 or 2 week treatment period. Certainly additional cases would be needed to help identify what duration of treatment would resolve a meconium ileus, and there may be a number of other factors that inform response and timeliness to response. And so I think we simply need more data to answer that question fully. But I think in regards to a future scenario of an infant where meconium ileus is identified, certainly we were able to show the benefit for our infant, and the insurance company was resoundingly positively responsive in quickly approving the medication in the sort of landscape of where we are with modulator access today. And so the positive from our case is that by showing that benefit for our infant, that was able to help another infant demonstrate again that benefit and get early access in another case. And so I think we just need to be really mindful of documenting what we're doing, being cautious in monitoring, but also sharing our experiences and sharing that with all of the stakeholders who are involved in care of infants, whether that's pharmaceutical companies, insurance companies, hospital systems. I think it's an important case and series of cases to be aware of.
We have a question from the audience. Did this mom just cold call you, or did she go through her OB as part of a referral process? I can see an OB being very reluctant to refer be aware of the potentially actionable information about a CF diagnosis. And it seems we need to reach out to OBs about this changing landscape.
Yes, so we were fortunate in that this family, number one, has a highly proactive attitude and an extremely high health literacy and education level. And so they were very prompt to jump on what could be done and even just conceptualizing that. But we knew the family from an older sibling who's affected with cystic fibrosis.
Yeah.
So they were well known to our center and to our team for that reason. But I think the sentiment of building relationships with OB/GYN institutions and making these cases well-known within the community of not just pediatrics, but also adult cystic fibrosis care and obstetrics and gynecology is an important takeaway.
Should CF be part of prenatal screening?
I would argue yes.
Let's see. With the biology we heard before your talk, could you make an argument to offer ETI to women pregnant with fetuses with delta F508CF without meconium ileus to prevent nutritional challenges, to protect against CFRD, to protect against pancreatic insufficiency?
And so that's in an affected mother.
Yeah,
With
or an affected child,
Affected child.
but without evidence of meconium ileus. Should you administer this therapy to protect against pancreatic insufficiency, for instance?
I think if ongoing data collection shows that there is no harm that is perceived in those potential situations, CF is a lifelong progressive disease. And so far, the data that we have on lung function specifically, to go a different route with ETI, is that there is stability and that improvement is maintained. And so if we start an infant in a healthy health status, I guess I would say, so healthy pancreas, healthy lungs, healthy airways, healthy sinuses, healthy GU and reproductive tract, would it not be an important consideration to offer that if it were safe and effective? I think it's worth considering, absolutely.
Do you think maybe the most dangerous scenario would be that somebody treats in utero and then the baby loses access to drug and they withdraw, and then we have very little information about what the adverse effect from that would be?
Yes.
That seems like the biggest barrier. And I don't know, like, since you've done it and you managed to navigate getting a baby onto Orkambi, if you have any like insights into what should be done for that.
So I think the most helpful takeaway, I would say, is we just have to be as open and honest with our families during this whole process. This is relatively uncharted territory, and so we're informing health payers with single case examples of what has been done. And so I'm excited that there will be a lot more data to share and to show that I think will hopefully be supportive of protecting infants, both in utero and after birth, that will make access to these medications more feasible. But I think until that data is available, we're not there yet. And so we have to, as we are currently doing, just do the best that we can and be transparent with families about that.
Another question here from the audience. Shouldn't we be doing this in a controlled research setting?
That would be ideal. There are many challenges to health research in pregnancy, and certainly I think it would be a challenging study to recruit for, but I wouldn't say that it's impossible. I think we're essentially trying to replicate that type of environment as best we can in the clinical setting until a study of that nature may move forward.
All right, that was excellent.
Thank you so much.
Yeah.
All right, I am pleased to welcome our next speaker, Dr. Romina Fiorotto is an assistant professor of medicine in the Department of Digestive Diseases at Yale University, and she's going to be talking to us about the pathogenesis of CF liver disease and implications for treatment. Welcome.
First of all, thank you very much for this kind invitation today to talk. Let me go. Yeah. Okay. Thank you. So I don't have any disclosure except the fact that I'm a scientist. So you will hear from me more from the basic point of view of the pathogenesis of liver disease. Okay. So CFTR in the liver is expressed on the apical membrane of the biliary epithelium on the cells called cholangiocyte. And together with an anion exchange 2 is responsible for the fluidification and alkalinization of the bile along the trip toward the duodenum for the digestive need. Overall, 30% of CF patients have hepatobiliary involvement, so a good amount, but only 5 to 10% of them develop a severe liver disease. And however, the liver disease itself, when it's severe, accounts for 2.5 to 5% of the mortality and shorten of life expectancy in these patients. And what is very interesting is that despite the overall survival increase in this patient, these numbers are not changing for the liver. So the other day, there was a workshop about the update in liver disease, and there was a lot of discussion about how to define CF liver disease. And indeed, is because we have several manifestations of the disease itself. And so it's hard to define it. And in particular, here I try to kind of summarize them. We have some very not severe implications such as steatosis, elevated liver enzyme, sometimes persistent, and cholelithiasis. And then we have, for example, focal biliary cirrhosis that is more severe because it's more common in this disease and can evolve into multilobular cirrhosis and be complicated by portal hypertension. Moreover, recently, and was outlined also the other day at the workshop, we are seeing patients with non-cirrhotic portal hypertension. So here is, I want to give just a couple of examples of these manifestations. And here, for example, we have, this is from a recently review on Journal Hepatology, an example of a transplanted 8-year-old kid in which we can see biliary cirrhosis that was complicated with portal hypertension. And you can see from images how the liver appear all nodular at the outside itself. And then if we go and we look at the histology, we see these big fibrosis, these bridges of fibrosis, and this proliferation of bile duct. And in some of the bile duct, we see accumulation of material. Another example is here. Here we have, these were other 2 patients that were transplanted, and in this case, we don't see the same phenomenon. We don't see cirrhosis, but they had to be transplanted because of portal hypertension. And what we are seeing in these cases is that there is more a vascular implication, and mainly an obliteration or a disappearance of the portal veins. And these resemble kind of what was also called, is very similar to idiopathic non-cirrhosis portal hypertension. And what is hypothesized, the mechanism is not real known, but what is hypothesized is that this is related to sepsis or, for example, to a prothrombotic state. That could be the case, for example, in CF because of inflammation. And here is another case in which, we have the coexistence of biliary cirrhosis and vascular lesion. So itself is very complicated. And so making complicated manifestation is also difficult to find treatments. And so far what we know, the current treatments options for CFLD are not really great. We have ursodeoxycholic acid that has been forever as a treatment to prevent or delay the progression, but there are several studies now that say that there are no evidence for beneficial of this therapy. And what we have is the management of the portal hypertension or lately the liver transplantation. So most of the reason why we don't have treatment is because the pathophysiology of this disease is still not clear and is actually evolving. So from the pathophysiology point of view, what has believed so far is that CFLD is caused by the secretory defect itself, that here I call the secretory defect hypothesis. And that's because, as I have explained, CFTR is on the apical membrane of the biliary epithelium and allow the bile flow toward the duodenum. But when CFTR is not working, what happens is that the bile change in composition and amount. And so we have accumulation of endotoxin and other products that would then provoke a chronic inflammation to the liver. However, these explanations don't completely match with what we see in clinic because not all of these patients develop the liver disease, even if they have the secretory defect. We have seen that sometimes treatment that would allow better the bile flow still don't have an effect on this patient. And also the fact that, just a small percentage then progress toward a worse disease. So what we think is that we need like a second hit or multiple hits to then develop the liver disease. And, So many years ago still, our group proposed the idea, we starting from a model that was created by Friedman in Boston, and showing that if we treat CFTR knockout mice and wild-type mice with DSS colitis, and this was just a way to increase the intestinal permeability, we see that the liver of the CF mice develop a histology here in which you see inflammation and bile duct proliferation that kind of resemble what we see in the patients. But this doesn't happen with the wild-type mice. We then further characterize, and we saw that also the biliary epithelium, biliary cells itself, when CFTR is lacking, they have a structural defect. And also when they are challenged with LPS, for example, so gut-derived bioproducts, they are more susceptible and they react with an over-inflammation. So this made us think that the gut actually play a big role in the CF liver disease. And indeed, we know, and we have seen also from the previous talk, that GI complications are common in CF patients. Meconium ileus, the distal intestinal obstructive syndrome, small intestinal bacteria overgrowth. But not only that, there are several studies showing that we have dysbiosis, we have increased permeability, and so on. And so what our group, is proposing now is the gut-liver hypothesis. And indeed, what we have done is try to understand in which way the gut could affect the liver itself. So going back to the lab, to the bench, what we have done is we have used a mouse model. In particular, we have compared CFTR knockout mice model with wild-type mice, in which we have CFTR expressed both in the intestine and the liver. And in the middle here, you see we have these mice that are gut-corrected, so they have the human CFTR in the intestine, but not in the liver. Here you see an RNA scope that is actually a probe that we use to show that we have CFTR, human CFTR specific in the intestine, but not in the liver. And then what we did in these mice is we collected their microbiota at the time of the weaning, and then after we co-house them, because that's a way to normalize the microbiota and have a clear picture of what's going on there. And as you can see here in these graphs, we we found that there was a decrease in the diversity, both at the 3 weeks, so at the weaning, and after the cohouse is maintained. So this tells us that the genetic defect itself is creating this microbiota lack of diversity. And then if we compare the composition of the microbiota among these 3 mice at age 3 weeks and 6 weeks, we see this gray bar appear that are gamma proteobacteria. So we have a bloom of gamma proteobacteria in these mice. And if we compare with the gut-corrected, we don't see these gamma proteobacteria, meaning that the correction of the intestine itself would make the microbiota more similar to the wild type. We then went to look at what happened in the intestine, so the intestinal phenotype. And indeed, if we compare the 3 genotypes, we see that the CFTR knockout have increased, and it's quite consistent permeability of the intestine, but not in the gut-corrected that is similar to the wild type. And if we take and we scrub the mucosa of the colon in these mice, and then we run a proteomic array, we see that many inflammatory mediators are present in this mucosa in the CF knockout, but not in the gut-corrected. So we then look at the liver of these mice, and we see that the CFTR knockout have an increase of biliary cells here. This is a staining for CK19 that is a marker of biliary cells. And for liver people know that when we see proliferation of bile duct, that means there is a damage and the bile duct are reacting. So that's the way how we measure. And we see that this is significant in CF mice, but not in the gut-corrected. And the same when we look at CD45 for inflammation, we see that we have these cells all attached to the bile duct in the knockout mice, but not in the gut-corrected. We also did the proteomic array also in the liver, and we confirmed what we see in the intestine. So CFTR knockout mice have increased inflammatory mediators in the liver, but not the gut-corrected. We then, to try to better characterize the inflammation, we did single-cell RNA-seq. I don't know if the audience knows this methodology, but actually we are able to capture the transcriptomic of each single cell. So we can take a tissue and do a single-cell preparation and then know exactly which cell we are looking the transcriptomic. And here, what we have done this from the portal space of these mice, and here you can see all the cells that actually we isolate. But then if we go to look at sample-wise, based on the mice in which we were doing the single cell in the liver, we see that in the knockout mice, we have this increase of T cell and neutrophil, as we have previously also see histologically. And if we look at the biliary cells, and we do at the genes that are upregulated in the biliary cells of knockout mice versus the wild type, we see that there is an increase of gene for attracting neutrophil in response to LPS. So there is something that connects with the intestine there. Another interesting feature that we saw is we look at the vasculature. And we see that also the vasculature has some feature of inflammation, going back to what we have seen with the vascular involvement that lately we are seeing. Then, what was our question? Main question was, is the microbiota itself that is causing the problem? So we took the wild type, gut-corrected and CFTR knockout mice. We took their stool and we transferred in germ-free mice that were wild type, and then we look at their intestine. And here you can see there are no differences in terms of the microbiota composition. And also the permeability, there were no differences. What about the liver? The liver also, we didn't see any CK19 increase or CD45. And what this experiment mean is that it's not itself the microbiota, but it's probably the combination of the microbiota with the inflammation of the mucosa that is contributing there. So next, we try to target this. And so we did a treatment with antibiotics, neomycin and polymyxin, to try to see if we can rescue this phenotype. This was a long treatment, so 1 month. So I believe we are taking out some of the bad bugs there and improving also inflammation. And indeed, what we see is an increase of the diversity in the CF mice and also an amelioration of the permeability. This was very significant. And also when we look at the liver, we see a much higher decrease in inflammation. So just to give a summary of this first part, what we have seen is that CFTR in the liver, when it's dysfunctional, it increases the cholangiocyte, the biliary cell susceptibility to bioproducts coming from the intestine. And the loss of CFTR in the intestine causes mucosal inflammation, reduce intestinal barrier, and alter the composition of the microbiota. And the gut-corrected mice, so if we correct CFTR in the intestine, we decrease the alteration in the intestinal milieu in the CF intestine are required to maintain this dysbiosis. So if we correct the intestine, the microbiota would change. But if we recover CFTR function in the intestine or we modify with antibiotic, we have a significant improvement of both the intestinal and the liver phenotype. So what tells us, what should we target? So I think that there are common factors here, that is the impaired CFTR function, but another common important factor is inflammation that we should keep in account. Here we are talking about these modulators, and for the liver disease, this is becoming a lot of discussion also from the recent workshop, because we don't have sufficient data, because we have the problem that this patient, it could be hepatotoxic, because we know that these compounds these modulators are actually metabolized by the liver. And indeed, there has been some cases of hepatotoxicity. So it's very difficult to have some data about the liver. Here, I put on the right, there is the link of the study PROMISE. And I think with what we have seen now, we should look at also what happened into the liver-gut axis and have a better picture of that, not just keep the data separated itself. What are other potential treatments that would come to our mind, thinking to what we have seen here? So it would be something that comes to my mind that we are using for other biliary liver disease, like, for example, NeuroDCA that is now in clinical trial 3 and has shown not only to have an amelioration of the cholerasis, but also to have an intervention on the intestinal T-cell mediated inflammation. Or, for example, the FXR agonist as well have an anti-inflammatory property, and also act on the bile acid. I didn't talk about bile acid today, but there is also a problem in that. And other anti-inflammatory agents. Or we should also target the dysbiosis, and so think about when we see someone with, for example, mild liver manifestation, about the use of specific antibiotics or osmotic laxative or probiotics. So to conclude my talk here, my take-home messages are that CFLD shows a very heterogeneous spectrum of manifestation, and a pathophysiological mechanism is probably not fully defined, but our experimental data are pointing toward the gut-liver axis. And based on the experimental data that I show it to you, so correcting the CFTR function, but also targeting inflammation and gut dysbiosis could ameliorate or prevent the CFLD. So there is a need for the research and for clinical trial to investigate how this modulator could act into this axis itself. And then finally, I just want to acknowledge a lot of people in our lab and the CF Mouse Model Core and all our funding institutions. Thank you.
Thank you for such a fascinating talk. This is really groundbreaking work and really exciting. We have quite a few questions. Dr. Zachary Sellers wants to know, do you see increased permeability and inflammatory signatures in all parts of the intestine or just in the colon? And also a follow-up question, can you clarify where your initial microbiota changes from stool samples or intestinal mucosal samples? I can repeat that if you need.
Yeah, so regarding the permeability, so the way we measure is we give dextrin, a fluorescent dextrin by gavage, and then we collect the blood. So we really have no idea what part we are really looking into, but I suppose is more, so where it is absorbed, so probably from the distal part of the intestine. The other question was about, was the permeability, and the other was about the microbiota, so was from stool. But we are collecting data about mucosa as well.
Yeah. So another question, liver disease and CF seems to progress often during adolescence and early adulthood, and then often plateau thereafter. How would this two-hit proposed mechanism of gut dysbiosis explain this phenomenon?
So I think this is actually explaining in the sense that along your life, you can have multiple heat in that sense. So it's not just the meconium ileus at the beginning, but it could happen that you have a certain inflammation there that is kind of chronic. And when there is maybe some antibiotics that they take or something that change that, you have this bloom, and then you have the transfer of bioproducts, and then when you start developing.
Another question here, would an anti-inflammatory diet, such as a Mediterranean diet, potentially improve the gut microbiome, decrease gut inflammation, or improve CF liver disease?
It would be interesting to see. Yeah.
I was wondering if there's any precedent for this gut-liver axis in other established diseases
In the
that are
liver,
well known,
yes.
like such as Crohn's disease, where they
Yeah. We have the example of PSC. It's
Yeah.
associated with Crohn's disease.
Yeah.
There is a high association.
Yeah.
And some other, like PBC or autoimmune hepatitis, now we are seeing all of these disease of the liver. I mean, all the bioproducts that come from the intestine go through the portal circulation to the liver. So that's the way they get up to the liver. So there is a strong connection there.
There's people with CF are exposed to a lot of antibiotics
Yes.
over their life. And, in many cases, we know which antibiotics they get. Is it possible to decipher from the types of antibiotics people receive which ones are going to be protective against CF liver disease?
So that's my point, actually, because we always say the CF patients take a lot of antibiotics. But if you probably target specific bugs, then you could have an effect there. So could also be the fact that not all of these patients develop the liver disease because they take maybe some antibiotics that are kind of protective along their life. I don't know. But certainly if we could target specifically specific bugs, I think they could be protective for the disease. Yeah.
That was a fantastic talk and really sort of opens our mind to new potential
Yeah,
mechanisms.
I think we need to think these two things together. Yeah.
I have one more follow-up question before we. I've been fascinated by the evolving story of what is CF liver disease. Is it a biliary disease? Is it a vascular disease? And I'm just wondering how you conceive of that. Do you think that there's sort of two intertwined ends on a spectrum of disease? Do you think that the gut impacts the portal musculature?
So I think it's more inflammation that could be more than the musculature. I mean, from the single cell data, I look after I was reading the literature and I see that this is coming out. So I say, let's look at our single cell data and look at the vasculature because we can really separate the cells. And they look inflamed, reactive. So probably is the entire process that make them inflame, and maybe also the bacterial products. I didn't show here, but we see some bacteria in the liver.
Okay.
We could catch them, a few of them.
Yeah.
And some enterococcus especially that we know are very damaging there. Yeah.
There seems to be this
But,
emerging.
so my question, this is more for the clinicians about this vascular involvement, because I'm been talking with colleagues and they say, yes, it's true, but it's not so, the percentage is very low. So I don't know how much is the vascular involvement at this point, but there is. And it could kind of be explained in the terms of the inflammation.
Right. To be continued. Thank you.
Thank you very much. That was excellent.
All right. Thank you very much. And I will welcome our final speaker, Dr. Raksha Jain. Dr. Jain is an associate professor of pulmonary and critical care medicine at UT Southwestern. And Dr. Jain will be talking to us about male infertility in the modulator area. Welcome, Dr. Jain.
All right. I'd like to start by thanking the moderators for having me today. And if you think about the content of this session today, we talked about things we don't talk about much. I think for my talk, the other addition I would make to that is things we don't know how to talk about well and much. And I think that's a key theme to think about when we think about this topic of male infertility in our population with CF. There we go. Okay, these are my disclosures. So, I think as we've heard about it a lot this meeting, we've really entered a new era of CF. We've heard that the median predicted survival age for people with CF is now greater than 50. There's been a tripling of the number of people who are married or living with someone else amongst our adults with CF. There's nearly 4 times the number of people with a college degree now amongst our population of people with CF, and many of those are considering parenthood. So I think this topic is becoming increasingly important. And with that, there's really a number of questions we have to think about, and these are just a few that I'm going to highlight. But one of those is when and how do we bring up fertility in males with CF? I think many of us who take care of patients, whether it's in the pediatric world or the adult world, are a little plagued with how to do this the right way. And I can't say that I'm going to have good answers for that, but I think I'm just going to highlight how we need to think about it. The other is educating them on options for assisted reproduction, which means we have to educate ourselves as well. There's also thinking about what's the impact of modulators on infants with males with CF. We've actually talked a lot about infants of females with CF, but not a lot about males with CF. And then can we treat or rescue fertility in males with CF? We've also heard a lot about that topic from a GI standpoint today, but what about fertility? So just to give you a little bit of brief background, fertility in males with CF is very common. It afflicts about 95 to 98% of males with CF, and it causes congenital bilateral absence of the vas deferens. This means that males with CF have very normal sexual function and normal sexual desires, but they lack sperm in their ejaculate. The ejaculate may be smaller in volume at times, but very importantly, this CBAVD results in infertility, but not sterility, and we have to highlight that to our patients. This is a nice graphic, and for those of you who were at the reproductive section yesterday, I know Chris Fortner highlighted this as well, which is that the vas deferens is very sensitive to CFTR dysfunction. This is a graphic that was taken from Rowe and colleagues' paper back in 2007, where if you look at the percent of CFTR activity on the x-axis and sweat chloride on the right axis, you can see that as you move leftward and the percent of CFTR activity goes down and the sweat chloride goes up, you can see that right there in the middle, let me see if I have a pointer, maybe I don't have a pointer, but right there in the middle, you see CBAVD, and that actually starts occurring often when slut chlorides are less than 60. So it's much more sensitive than some of the other organs that and manifestations you will see in CF. And this absence of CFTR results in atrophy or absence of the structures from the epididymis to the seminal vesicles, leading to this obstructive azoospermia. And very importantly, this occurs in utero. So by the time a male is born with CF, this has already occurred. So how do we diagnose this? And there's multiple different ways, and you may all have your preferences, but you can, their physical exam has not died, that is still an option on how to diagnose this. You do need to be apt at doing this, and there are those who know how to palpate for the vas deferens and those who don't. But you want to be sure that you're doing this accurately. But if you lack being able to palpate the vas deferens, this can be one of the signs and diagnostic tools. The other is a semen analysis. I think you might have also heard in the reproductive session that you can hand your patient a brown bag and they can collect a semen sample, and you can have them check whether there is sperm in that sample, and that's another way. And the third is through ultrasonography, which I think is a commonly done, whether you use a scrotal ultrasonography or transrectal ultrasonography. And you can just see one depiction here where you can get a very nice image of the vas deferens or absence thereof accordingly when you do the right testing. But it is very important to do this because, again, there is a small population of males that do have a vas deferens, and we don't want to miscounsel those people either if they do have a vas deferens. What are some of the other etiologies of infertility in males with CF that we also don't talk about often? And that is that CFTR can also be important in spermatogenesis itself, that sperm concentration and counts have been found to be lower in males with CF who are undergoing sperm retrieval than in control. So there may also be a second component to the impact of CFTR on fertility in men. There's also hypogonadism, which I think is more common than we realize and also understudied and underevaluated even clinically. And men with CF had been reported to have lower FSH, lower LH, and lower testosterone levels than non-CF men. And finally, because of this hypogonadism, we often have a number of men on testosterone supplementation. There's also a lot of men that choose to go on testosterone supplementation on their own for other reasons, but this can also decrease spermatogenesis, so it's important to counsel them on this when they're using this therapy. So then just to move a little bit into when and how do we bring this up. I think the key message is as early as possible. And you're taking care of these people, you know the conversations you're having, but realize you need to do it sooner than you think. And I have to say I've made this mistake throughout my practice as well, and I'm still learning, but it's always something I wish I had brought up earlier. And I think if you're a pediatrician, a good time to think about it may be when they're teenagers, ideally, when you have them in a room alone, when you're counseling them on contraception. And I think we often forget the counseling on contraception in our males with CF because we think, oh, they're infertile, but we can't forget about sexually transmitted infections that our males can get, and that has to be a component of what we talk about. Another good opportune time is when you're doing transition education. I know our center has a transition education sort of bullet point time that when they're moving, that's their greatest time to make sure that they actually caught all the information in pediatrics that we ideally had hoped they had. Another great time is new diagnosis education. Maybe that's directed at their parents and maybe that's directed at them later in life, but that's another opportune time. And then the other is prior to transplant referral. I think we failed to think about that as well, that there are some implications to transplant medications that may be implicated in male sperm. And I think if we can have a conversation before they're en route of being referred to transplant, that's another opportune time. I mean, really, there is no unopportune time, but I think we need to be proactive because it's a hard topic for our patients. And I think that if we introduce it, they're probably going to come running and really welcome the conversation. So we have to normalize it. And I think the other part is share stories of your patients, of their successes, and make them understand it's not something abnormal or different, and that many men with CF have had wonderfully successful children, and that it's an option. But it's also important to educate them on the option. And the other really big challenge I think we all face is the cost, because it's also hard to educate them on the options and then think about the fact that they may not have the opportunity to actually an opportunity to use those options. So I think we have to really face it in a balanced way to make them understand that piece as well. So when you look at some of the common reproductive technology options for males with CF, what this requires is sperm extraction. As I mentioned, the majority of the men will have normal sperm. They just don't have the path, or as Natalie West calls it, the bridge for that sperm to get out. And most of these men can undergo these procedures quite easily and return to work often within 24 to 48 hours, and maybe not to heavy work for another 5 to 10 days. But if you look, these are just nice, easy pictures on how to think about these different procedures. So one is TESA, which is testicular sperm aspiration. That's up on the top left, and that's just where there's a fine needle aspiration done in the testes to recover viable sperm. They retrieve it under the microscope. It's, again, often a day procedure and quick recovery. There's testicular sperm extraction, which is TESE, and that's a little bit of a larger procedure where typically tissue is taken from the testes. This tissue is processed to retrieve the sperm, but you can obtain a lot more sperm. It tends to be highly successful. There's PESA, which is percutaneous epididymal sperm extraction. That's, again, a needle aspiration procedure, but this time into the epididymis rather than the testicles. And then there's MESA, which is microsurgical epididymal sperm extraction, again, where it's a slightly larger surgery. They do retrieve a lot of sperm here, but it's directed at the epididymis rather than the testes. And I am certainly not an expert in this. I would highly encourage you to work with your urologist or your fertility experts in your centers, and again, pair with them, as we heard before about pairing with our OB-GYNs, to have a conversation with your patient and with them about what the best one might be for your patient. So after the sperm extraction, then what are the options for them after that? And there's really two main options once that sperm is extracted. One of these is in vitro fertilization, and the other is IUI, or intrauterine insemination. The in vitro fertilization allows the sperm and the fertilized egg to be mixed together in a petri dish outside of the body to create embryos that can either be used right away or they can be frozen for later. The success rate on those are quite relatively good, 40 to 40%. But does involve their partner being on hormonal therapy, et cetera. So that's one thing to think about as they're thinking about these options. When it comes to IUI, or intrauterine insemination, that's where the sperm is basically directly implanted past the cervix and into the uterus of their partner. In that case, often there's no need for hormone medication. Sometimes there might be, but it's less so. This can be associated with some risk of infection in their partner, and the success rates are slightly less. And there's also variability in some of the costs of these. I'm not going to get into it because it can vary quite a bit, but that's another thing that you may want to let your patients know, to talk to their fertility specialists about the variability in that. So then moving a little bit into modulators and the impact of this on males planning to have children. So a couple things that we should think about in this modulator era. As I mentioned earlier, that the ejaculate in men with CF tends to be a little smaller in volume. There has definitely been reports out there with the use of modulator therapy that this ejaculate may be more increased in volume. And actually, there's been reports of men who reported testicular pain after starting their modulator therapy. And I know a question that has come up, and again, we're not very good at addressing, is we've had some men say, does this mean I'm fertile now? And we have to be, very thoughtful and careful about counseling them on the fact that they may have increased volume in that ejaculate, but there is not reason to believe that there would be any sperm now in that ejaculate if it did not exist before. So that path, as I mentioned, was obliterated in utero, so they don't have the ability for that to get corrected with CFTR modulators after being born. At least currently. Science is moving fast, but at least currently. And the other is that we also need to assume, just like we're seeing that in mothers who have CF who are using modulators, that those modulators are getting through the placenta and they're getting through their breast milk. I think we also need to assume, while we don't have great data yet, that these CFTR modulators are reaching the semen. And that sperm is being exposed to CFTR modulators. So this is also important. Just like we're counseling our mothers with CF who are thinking about having children, we have to counsel our men with CF who are thinking about having children too, that this is a possibility. It's also important to let them know that the half-life of sperm, or the life cycle of sperm, tends to be out 60 to 70 days. So if they were looking to truly be off of a CFTR modulator before having their sperm retrieved, that it would actually take them being taking off quite a bit, 3 months or longer. And, as we know, there's many things to think about that when they come off particularly highly effective modulators, that their health could destabilize. We've heard cases of withdrawal syndromes, et cetera. But that's really the amount of time they would need to think about. It's not the week prior that I think we've had some people think about. It's quite a long time. And then the other piece to think about is that throughout their partner's pregnancy, when that partner gets pregnant and they are having sex, that there can also be transmission because that semen is exposed to CFTR modulator. There can also be exposure where the partner gets exposed to the CFTR modulator through semen, and then it's absorbed, and then again the infant, the newborn, the unborn infant can be exposed to modulator in that route too. So these are all things, again, we have to have conversations about. We don't have great data, but we need to let them know that there are these possibilities. And if they want to avoid that, then they should use condoms during their partner's pregnancy. So this is one of the first reports, and this was is being presented at a poster here, poster 17 by Dr. Taylor Kauser and colleagues, and she presented these data in a session 2 days ago, really looking at some of the first reports of the fetal impact of CFTR modulator use during assisted or natural reproduction and partner pregnancy in males with CF. And in this study, she and Dr. Kazmierski and several others surveyed providers caring for men whose partners became pregnant while that man was on a CFTR modulator. So this is the first of this kind of data we've had. They captured these surveys between August of 2021 and September 2022, collected 42 surveys. The mean age of that population was about 32. And I've just highlighted, there's a lot of data, but I've just highlighted a few points, which is in 5 of those men, or 12% almost, there was a first trimester miscarriage. This is not atypical. This is actually very in line with the national data, so not something to be alarmed about. There was 4 who stopped their modulator therapy prior to sperm retrieval, and of these, 1 of the men had a decline in his health after stopping. There's 4 infants who did have a report of hypoxemia requiring NICU stay. Whether or not that's related in any way, we don't know. There was no congenital anomalies reported, and none of these babies were born with CF. So, and there's much more about this story in that poster 17 that I encourage you to visit, but at least it's similar to what we're seeing in the trend of CF mothers that are having babies. This is at least a first signal that I think we hopefully don't have to be alarmed about our patients who are staying on their modulators who are thinking about reproduction. So then I think the other big question, and this has been a highlight of this session so far, is can we rescue or correct fertility in men with CF? And I think I've stated multiple times already that because of the absence of the vas deferens that males are born with CF, we are not, to my knowledge, going to be able to recover that with modulators after they're born. But then comes back to this topic that we've hit on a couple of times today already, which is there a possibility for in utero recovery? And this ferret model has been brought up a few times today already very nicely. Dr. Engelhardt and colleagues that have studied this ferret, and they have this G551D ferret that has been highlighted, that when they looked at these same pups, so these are G551D ferret mothers that were exposed to ivacaftor and had G551D homozygous ferret pups that were males, and they took a look at these pups who had been exposed to ivacaftor in utero and looked at the reproductive organs afterwards. You can see here in these pictures from their paper that the left-hand side is knockout ferrets, where you see this absence of the vas deferens that's in the red arrows, and the right-hand side is the G551D homozygous pups that were exposed to VX770 or ivacaftor in utero, and you can see very nicely the development of a vas deferens in these ferrets. So these ferret pups that were males did have a rescue of their vas deferens by exposure in utero. So we've also heard a little bit about some of these cases that I'm going to highlight here. One of these is that CFTR modulator exposure to a fetus who was found to have a false negative newborn screen. This was published by Chris Fortner and colleagues. I thought I saw Dr. Fortner in the audience, but so this was a case where it was a female with CF. So this is a person who does have CF, who is Delta F homozygous, who conceived with a male that was an F508 carrier, and 6 weeks after starting ETI. This patient chose to stay on ETI throughout pregnancy. In about 20 weeks, there was a concern for echogenic bowel in this baby. That resolved at 32 weeks, and there was a baby girl that they had at 39 weeks who was born normal weight, no meconium ileus, and no current pulmonary findings as of this publication. And you look at some of the values here on the right-hand side, and you can see that the infant had a normal IRT of 37. The infant did have 2 CFTR mutations, F508 homozygous mutations. The fecal elastase was greater than 500, the sweat 60 and 67, and the LFTs were normal. So a very, a nice indication of what we heard a little bit already, that 1, we know these babies are getting exposed. 2, we know that they may get missed on newborn screening the way we have it now. And I do hope in studies, although we don't have a specific prospective study designed for this type of analysis, with the Mayflower study that is going to be capturing almost 300 women prospectively around the country, I certainly wonder that we might run into a scenario where there is a CF baby born to those mothers, and that would be an opportune time to study this type of question. Now, granted, we may find a lot of variability, that it may take a number of case reports together to really understand this. But I think it really lends itself to the question of, should all infants born to mothers with CF who are taking a highly effective modulator while they're pregnant, should their babies be screened for CF with CFTR mutation testing? And, I'm not a pediatrician or involved in the newborn screening world, but I know many of you are, and I really do think this is a question we need to address for people with CF. The other one I'm going to go through just very quickly, because I know Sylvia very nicely highlighted, this is her publication, and nicely highlighted this already. And this was just another example, in this case, a pregnant female who is a carrier, whose baby was found to have CF, who the mother chose to start ETI. There was a rescuing of the meconium ileus in this baby. And again, when you just look at some of the infant numbers here, she already highlighted this nicely, but in this case, the IRT was elevated at 104. This was still a homozygous delta F baby. The fecal elastase was 240, sweat test similar to what we just saw of 60 to 64, and normal LFTs. But this also shows you, just amongst these two cases, the IRT and the fecal elastase, despite the same mutations and maybe not similar exposure, because this baby was started on ETI a little bit later than the other, or not, the baby wasn't, but the mother started ETI a little bit later than the other. But you can see that there is a difference in IRT. So it kind of again points to the fact that we can't learn off of just one case. So I think we all need to make sure that we're sharing or publishing our cases in different ways. So just recently, and I think this was just highlighted at session yesterday and not yet published, so I don't have all of the data, and if Dr. Fortner's here, he can always chime in, but Dr. Fortner very nicely highlighted a case. The last 2 cases I mentioned to you were baby girls. And I think we've been waiting to see a baby boy, and Dr. Fortner did report a baby boy yesterday in his session where that he had a mother with CF who had a baby boy. This baby boy is a delta F508 baby boy with a stop codon mutation. So in this case, 2 different mutations, the second one being a stop codon mutation. This boy was exposed to ETI in utero, born with a borderline sweat test, and because it's not published, I don't have all the exact numbers, and I'm sure Dr. Fortner can answer that. He did present that yesterday. Was born pancreatic sufficient, and has a vas deferens. So I think this is the first human case that really we know of, and I'm sure he and his colleagues are going to be publishing this, but until now, there had not been, a human case of this reported, and it really does go to show you that I think, one, the animal models that we're learning from, particularly the ferret, et cetera, are amazing. And 2, there is a way to correct or treat fertility in men with CF, but this is, again, I think we all know as we're sitting here, there's some significant ethical challenges that we have to think about as we forge ahead on this. And he and his team are continuing ETI treatment for this baby because just like we heard a little bit about when it comes to recovering pancreatic function after a baby is born and facing pancreatitis after that baby loses access to a modulator potentially, this is another challenging one that I don't think we know what it will look like if a baby boy is born with a vas deferens because he had exposure to ETI in utero and then loses access to ETI. What is that going to do? I mean, I don't even want to know. That kind of breaks my heart. But I think We have to think about that because that may very well come up, and I don't think we're going to know what to do. And, we as a community sort of have to figure out, again, these conversations with these families about what it may mean to get exposure in utero and whether or not we can get exposure after they're born. So with that, I just want to highlight also this group that just very recently formed out of support from the CF Foundation and TDN, and is sort of a subgroup of our original Women's Health Working Group that's now called the Sharing Working Group, where we're studying sexual and reproductive health in people of all genders. And this Men's Health Research Working Group just formed and is being chaired by Tracy Kesmersky and is made up of a number of different people with wonderful expertise, from endocrinologists to urologists to pulmonologists and to community members with CF, to make sure that we get their input as well. But their goal is really to tackle a number of these different topics that we touched on today. Amongst this, and this came out of publication by one of the members on this committee, which is tackle infertility, including the impact of highly effective modulators, including better understanding it, again, conversations, sexual and reproductive health care provision to help us understand how to educate our patients on this topic, and also hit the topic of parenthood, which I think is another big one that I didn't really touch on today, and then hypogonadism, which I really glossed over, but is really important to our men with CF. So I'll just summarize with the highlights, which is I think we know that 95 to 98% of our males are born infertile due to absence of the congenital bilateral absence of the vas deferens. We have to counsel our patients about this and find the right way to do it and not be shy. In this new era of CFTR modulators, while we're seeing an improvement in fertility in our women with CF, likely due to thin cervical mucus, changes in the pH, et cetera, we're not likely to see this change in already born males with CF. We have to discuss these risks and benefits of CFTR modulator use with our men currently thinking about having babies, and with our patients who are having baby boys, and we have much to learn. And I think these case reports of the impact of modulators in utero are absolutely intriguing, and I think we have a lot to think about as a community. So with that, I just want to thank a few people, including some of the patients and families that have, at our care center and other areas, that have contributed to this topic, my own clinical care team and research team, who is always a huge support to me, and then our Sharing Working Group, who really started a lot of these conversations and doing work in this space. And thank you for your time.
Awesome. Thank you so much. We have about 5 minutes for questions, so I'll let you take it away,
So
Tony.
the first question we have you seen more testicular swelling or pain in men who are pancreatic sufficient versus pancreatic insufficient?
That's an excellent question. I can't say that it certainly has not been methodically reported that way. In general, the testicular pain has been glanced over, I think, in general. I'm not sure there's been any really clear reports out there. So I can only give you my own anecdotal experience at my center. And, we probably have had 3 to 5 men after starting ETI, and we have an adult center that's about 350 patients. And so if you think about half of those being men, and of course not everybody's a modulator, it's a small percentage. So it's really too hard when I think about those 3 to 5, they were all pancreatic insufficient. I don't know that I could call that any kind of trend off of those numbers, but that is a really, intriguing question.
Let's see, another question. Do we have any data on the 3 to 5% of men with CF who do have a vas deferens? Do they have normal sperm counts in their ejaculate?
So that's a good question. And, I mentioned that there can be multiple mechanisms to this infertility. I don't know of a publication, anyone's welcome to chime in if they do, that's actually looked at that population that has a vas deferens and done sperm counts. That's very interesting because, as I mentioned, CFTR can impact spermatogenesis. But yeah, I think that Jen may have a comment in the back about it.
So I don't know that the sperm counts have actually been evaluated. They have found in children, so 2 of the males who were in that work that Rasha presented actually had their children by natural.
Yeah, so I guess, in other words, that highlights that they're capable of having children, whether or not they have a lower sperm count, or if you took the whole population, whether that would be lower, I'm not sure, but maybe I'm open to input.
Doug, with the parents that obviously you brought at the time, so as long as they get through early adolescence, on 770, you take them
Really?
Oh, that's great to know. I don't know if you all heard that basically in their ferret model, if they are born with a vas deferens and you take them off of their modulator in adolescence, they stay fertile and that does not close up or obliterate or anything else from what I'm hearing, right? That's really great information. Thank you.
Wow. I'd like to hear more about the hypogonadism because, there are many patients that we have in pediatrics who I feel don't quite reach their potential for growth or development. And I think that many of us in pediatrics are kind of reluctant to bring it up. Maybe we should be talking more to our endocrinologists.
No, I mean, I think you're right. It's been an understudied area for a while, and I do think this Men's Health Research Working Group is going to really focus on that topic. I know in practice, our clinic has actually started, we routinely with our annual labs do testosterone levels. The real challenge about it is you've got to do the right testosterone level and the right time of day. So these are meant to be done early in the morning. And that's hard because many of us have afternoon clinic. That's when labs are done. And so to ask them to go back and do it is a bit of a challenge, but we've started to do that. And I think they really appreciate knowing. And I think it's harder probably in the pediatric world, but I think the sooner you catch it and have conversations, the better. And I also don't feel like we have a good sense of the prevalence currently. We're using very old data, I think, to guide us on this topic. And this may be another area that has changed with the improved health and improved nutrition of people in CF that we may see less of it. But I don't know at all. I'm just speaking and guessing.
What age do you start screening with testosterone levels at? I'm just curious.
Well, I mean, I am in an adult clinic, so pretty much everybody that comes to our clinic, we do that on. But I mean, my opinion at least would be that I think we should do it very, very early. I mean, when young men are hitting that puberty age, I think for sure, in my opinion, it should go on the list of labs checked.
Yeah, it's challenging because different boys will hit puberty at different ages, and so you have to interpret the testosterone relative to where they are in puberty. And then the question of, is that pathologic or is that just their normal puberty? So it gets dicey in adolescence.
Yeah, that's a great point.
Well, thank you so much to all of our speakers today. This was a fantastic session. Thank you.